Hello, everyone. I'm Michael McNutt, Director of Events and Education with WEDI, and welcome to our seventh and final in the Road to Interoperability and Prior Authorization series, looking at small payer perspective. It's my pleasure to introduce Robert Tennant, VP of Federal Affairs with WEDI.
Thank you, Michael, and let me add my welcome. We have a wonderful program today. Next slide. We are very excited to bring you this series, and just on the off chance that you're not familiar with WEDI, I'll give you just a brief overview. WEDI was formed back in 1991 by then Secretary of Health and Human Services, Dr. Louis Sullivan, who was a practicing physician and frankly knew firsthand the challenges that payers and providers faced in exchanging health data. So he literally called into his office some of the leaders in healthcare and formed the working group for electronic data interchange. He charged them with developing some reports to improve the efficiency and effectiveness of electronic data interchange. And those two reports were folded into legislative language, which we now know as HIPAA. And in fact, WEDI was named in HIPAA as an advisor to HHS, and we worked closely with some of the key agencies, including CMS, OCR, and ONC. We do much of our work through our work groups, forums, and discussions. And really the central focus for WEDI is convening the industry, not just to complain, but rather to identify opportunities to collaborate and improve health data exchange. Next slide, please. So as I said, we do a lot of our work through our work groups. We have 18, and you can see here they span everything from all of the major HIPAA transactions, but we also have things like payment models and health equity. And we have the No Surprises Act task group, which is, of course, focused on the data exchange provisions of that legislation. Next slide. As Michael said, we've started way back, just 2 days after the release of the final rule. We had our overview presented by CMS. And you can see here all of the events so far are now up on our YouTube page. The one that took place just 2 days ago, focused on small providers, is going to be loaded very soon. So if you missed some of these or all of them, please take advantage. They're all free. And so, again, a good opportunity to do a deep dive into this very complex final rule. We could not bring this type of education to you without the wonderful support from our sponsors. Both Edifex and MCG have been very strong partners for WEDI's education efforts, not just with this final rule, but throughout the years. So thank you very much to them. I would encourage you, if this is an issue important to your organization, check out these two vendors. We continue the discussions. We call them post-game shows. So part of our goal is not just to educate, but also to identify critical issues need to be addressed either by CMS or by the industry at large. And so we have these post-game shows led by our own board chair, Ed Hafner. And it's an opportunity, again, to bring stakeholders together to do a continued dialogue into some of the issues, for example, that we'll raise on today's program. And our goal is to potentially identify some areas that need additional recommendations or guidance from CMS, and hopefully help drive some of their frequently asked questions. Next slide. For those that remember when the industry made its transition to versions 4010, 5010, and then the ICD-10 code set, WEDI created what we called the Strategic National Implementation Process, or SNP. And we, again, brought the industry together to help move forward with implementation of these final rules. And we plan to do exactly the same thing for this final rule, the interoperability and prior auth final rule, through various things, including events like today, but we'll also be developing work products such as industry guidance. We'll be conducting surveys on a regular basis. As we'll talk about today, not everybody is covered under the rule, so we'll seek to identify the return on investment for those not covered by the rule. We also really love to spotlight early adopters and learn from their experiences, and of course, identify best practices. We will be issuing recommendations to CMS. And finally, we'll be hosting an online community forum to allow stakeholders to submit questions, to have a dialogue, and really be able to bring folks together so they feel that they're not alone in their implementation efforts. Next slide. So let's talk about today. So we will do a quick overview of the final rule, and then I'll turn it over to one of the nation's experts on interoperability and prior auth, and that is Mark Scrimshire. We'll then move to our expert panel, and I wanted to personally thank Ferris Taylor for his willingness to step up and serve as the moderator for this panel. And you can see here, we really have a blue ribbon group of folks to walk us through this rule, and we'll do formal introductions a little bit later. This is an interactive event. This is a very unique opportunity for you as an attendee to ask questions of some of the leading experts in the nation on these topics. So please take advantage of the chat feature to raise issues or ask questions. And as always, the slides and full recording of the event will be emailed to all of you following the event, and feel free, of course, to share those with your colleagues. So with that, I'm going to just spend a few minutes and give you a very basic overview of the interoperability and prior auth final rule. Next slide. So as you all know, January 17th, the rule dropped. We have a hyperlink here in case you were looking for some weekend reading materials. Very important is the list of impacted payers. If you recall, back in December 2020, there was a proposed rule that came out right at the tail end of the Trump administration. It did not include Medicare Advantage plans. So that was changed in the reissuing of the proposed rule under the Biden administration. And so it was finalized as MA organizations, state Medicaid and CHIP agencies, and Medicaid managed care plans and CHIP managed care entities, as well as those issuers on the federally facilitated exchanges. So, but it does not include all health plans, and I know that will be a topic of discussion later. In terms of providers, the hook that CMS used, really the only one they have, is the incentive program. So those both on the inpatient and outpatient side, whether they be hospitals, critical access hospitals, or eligible clinicians, if they are participating in one of the incentive programs, they will have that as a measure. So we won't go into detail on that, but there is at least some hook to get the providers to support this. So in terms of what is in the final rule, there is a number of APIs, including the Patient Access API, which is a secure and public-facing API to make the patient membership coverage, claims, clinical, and drug formulary information available from the payer to the patient's API. And again, keep in mind, this is an app that is identified by the patient. And by law, of course, the payer must submit that data to the patient's API. There's also the Provider Access API, similar in that a very broad set of data must be transferred from the health plan to the provider's app of choice. And you can see here claims and encounter data without the financial information, US CDI data, and the prior authorization information that is available from the payer, excluding that, of course, for drugs. And then finally, there is the payer-to-payer API, which is the exchange. For example, a patient leaves one health plan to go to another. The patient can request that their information from the old payer be transmitted to the new one. So again, it allows the patient to get a more complete set of data from their new payer. And then we'll spend a lot of time talking about the prior authorization API, and we'll go into a little more detail on that in a second. And the same with improving prior authorization processes. So not only did they identify a technology to move the data, but they also identified some opportunities to streamline the overall prior authorization process. And as I said, there are measures for the incentive program. So next slide. So in terms of the prior auth API, the compliance date is a ways off. It's January 1, 2027. And the API must support three things. I know Mark is going to go into detail on each of these three. I'll just say CRD, the coverage requirements discovery, the DTR, the documentation templates and rules, and the prior authorization support, or PAS. And those are the three that must be supported under the rule. Next slide. Now, a little bit faster is the compliance date for the changing processes. So January 1, 2026, the impacted payers must provide the answer once they have all of the information requested. They must give the provider the answer within 7 calendar days or within 72 hours for what they call expedited prior authorization decisions. So again, it does not include all payers, and in this case, they excluded the qualified health plans on the exchange from this particular provision. The payer also must provide a specific reason for the denial. And finally, they must report a certain number of prior authorization metrics, including the number of requests approved, the number denied, and the number approved after appeal, and the average time between submission and decision. So again, the start date for those, January 1, 2026. Next slide. Again, I suspect Mark will go into these in more detail, but certain of the implementation guides are required, and you can see here CMS very kindly provided this good information. But if you go to the next slide, you'll see that the APIs for the three aspects of prior authorization, the CRD, DTR, and PAS, are all recommended but not required. So that, again, will potentially be a topic for discussion a little bit later. Next slide. And here is just a page of really excellent resources from CMS. And most importantly, they have developed a website or an email address. If you do have a policy question related to this final rule, they encourage you to reach out to the agency via the email address here, CMS interoperability at cms.hhs.gov. But again, wonderful resources, and I'm sure they're going to be updating these on a regular basis. And with that, it is my distinct pleasure to introduce Mark Scrimshire, who is Chief Interoperability Officer at Onyx Health. Mark, thanks so much for being here.
Thanks, Bob. Great to be here. And hopefully in the next 15 minutes or so, I can give you a quick overview of some of the key things, maybe a bit more from the technical perspective, but helping you think about how this is going to get implemented. In fact, what I might do is I am going to share my screen. So there's just a couple of things that I can reference to maybe help you as we go through this. One of the things we did in looking through that rule, Bob, you said it's some nice bedtime reading. That original rule that dropped on Jan 17th was about 822 pages. It was great for keeping you, getting you to sleep at night. Well, we went through and actually distilled this down. And so a couple of things I've also posted in the chat. So please put your questions in the chat as well. As to who is actually impacted as a payer, the simplest rule is if you had to implement the CMS 9115 rule, the original interoperability and patient access rule, you need to pay attention to this rule. You will have to implement this stuff. Okay, so there are obviously some nuances within that, as Bob pointed out. What's in the rule? If you are seeing my screen and seeing this this rather busy chart, this is not intended as an eye test chart, but you get the drift. If you see these light blue dots, that's really the things that were in the original interoperability rule. And what CMS is asking for in the prior authorization rule, CMS 0057, is a lot more extensive. It covers the operational changes. So you will have to gather metrics, okay? And Bob, you pointed to some of that. So the prior authorization metrics. There are also metrics required to be published to CMS around the use of your patient access API. So that has to be done by 2026. You need to be thinking about having those metrics being gathered by January 1st, 2025. So when you say it's 33 months away, things are actually getting a lot quicker, a lot sooner. The dark blue dots in this chart are all the new things that you've got to think about. How do they broadly stratify? There's changes to the APIs. Okay, we'll go into that. There is the need to gather metrics. And then there is the need to actually produce educational materials for both patients and providers. Why should they want to use these APIs? Okay, so you need to be thinking about all of this. You need to be finding the partner that can help you deliver all of this. Now, let's look at the various columns here. Everybody is focused on prior auth. So let's go to the fourth column, the prior authorization API. It actually consists of 4 implementation guides. 3 are actually recommended by CMS. So that is, if we go back to the slide that you were displaying, Bob, we've got the recommended IGs. So there is the Karen Blue Button Guide, there is PDEX, there is PlanNet, there is Formulary, there is US Core, and then there is coverage requirements, discovery, documents, templates and rules, and prior authorization support. So those are all of the guides that are recommended by CMS. And when we say recommended, the phrase I've used on multiple of these broadcasts is when you listen to CMS read the tea leaves, they don't just say recommended, they really say really, really, really recommended. You really want to be following these guides. And one of the things we haven't mentioned so far is that about 2 weeks after the rule dropped, CMS actually issued enforcement discretion. Now, what does that mean? Enforcement discretion, they basically said, and I will very quickly paraphrase, any covered entity can take advantage of enforcement discretion where they do not need to use the X12 transactions for prior authorization, provided they follow the implementation guides described by CMS in the rule. So all of these recommended guides, if you implement them, you do not need to use the X12 transactions to do a prior authorization. Still your option, but you do not need to do it. That enforcement isn't going away. They're just not going to act on it, okay? So this creates some interesting scenarios. The other things that are going on, ONC in December issued the HTI-1 rule, and they moved the goalposts for US core clinical data. So in your original implementation for patient access, you may have used US core 311. They now require you to use the new version by January 1st, 2026. We are expecting CMS to issue guidance to make that the case. They currently are still pointing to the old version. So the prior authorization rule, 3 elements: coverage, requirements, discovery. It really is a process whereby a provider can hit an API coming out of their workflow in their EMR and basically say, do I need a prior auth for this service or procedure? And within a few seconds, the answer would come back saying, no, you don't. Or if it comes back and says, yes, you do, that takes you to the next module, which is documents, templates, and rules. You as a payer or your utilization management vendor will have codified the data that you require for your medical guideline review for determining whether you're going to approve that procedure. And that is going to be codified into some FHIR content, a questionnaire and a clinical quality language that can hit the EMR, collect all the data that is necessary, let the provider fill in the blanks, and then they go to the third module, prior authorization support, where they submit the information and can be notified when there is a result. Okay, so that will handle the back and forth. Now, the industry is looking that you may be able to actually auto-approve maybe as much as 80% of prior auths before you even issue an X12 prior auth transaction, if you choose to do that. Okay, there are going to be further changes. You need so anybody that is implementing the prior auth set of guides, really any of these guides, there are going to be updates to the specifications that are recommended by CMS, because we need to take account of the changes that the ONC are forcing. So there's a lot happening in this space. You really want to find a partner that understands what's going on from the technical perspective. Now, those prior authorizations, we've dealt with providers requesting to a payer whether they need a prior auth and getting the answer. That information, the status of the prior auth, is also going to have to be made available to your members through the Patient Access API. It's also going to have to be made available through these other 2 new APIs, the Provider Access and the Payer-to-Payer API. So your Patient Access API is going to expand. It's going to include the status of those prior auths and the supporting structured clinical information that drove the decision. The Provider Access API is a new API. It's a bulk API. It's going to allow your in-network providers to come knocking on your door, metaphorically, and say, tell me what you know about my patients. And they will be able to download the information that they want that is basically a subset of the information in the Patient Access API. There are a few changes. The claims information will not have any financials in it for the provider, but it will have everything else, including those prior authorizations. So it will enable a provider to, for example, come and query and say, tell me what you know about my patients for the 10 I'm seeing tomorrow, and be able to pull that data back so that it's there and ready for when the patient walks in. The payer-to-payer API is another bulk API. It'll work a similar way to the Provider Access API, but it's intended for when members move from plan to plan. And so you can imagine when a member is going through enrollment in a new plan, that you could present them with a choice of saying, do you want us to go and get your old health information from your previous plan? They say yes. They give you their old plan information, like their member number and which plan it was and so forth. And you will be able to compile a list and send that using HL7 Fire to the old plan. And they will see which ones they match and send back saying, here's the list of members I matched. And that payer will now be able to make a query for all of the data for those matched members to get data going as far back as 5 years from the request date. So that's really geared towards continuity of care. So for example, if a member consents and they opt into this, whereas provider access, they opt out from sharing. So in payer-to-payer, they actively opt in, but when they do, you'll be able to get their prior authorization information. And since CMS is saying you shouldn't require a prior auth on something a previous plan has approved for 90 days after a member joins, you've actually got an incentive to know those prior authorizations. So you can couch this in a way of saying, if you share this information with us, we'll be able to, more smoothly onboard you and make sure that your services and procedures, etc., continue. So that broadly covers the 4 elements of the prior authorization from an API perspective. For providers, they are going to have to attest whether they're using the prior authorization API or not. So that I've gone through extremely quickly, but I'm sure there will be questions, and we said we'd do this by 1:30. So Ferris, I think I am ready to hand over to you and relinquish the screen.
Appreciate that, Mark. Excellent overview, and you're right. I think it's a perfect segue, Ferris, for you to have the panel introduce themselves, and we'll continue the conversation.
Thank you, and thanks, Mark. I did see one question from Janice, the 80% apprised to what?
Yeah, let me address that quickly. Some of the issues about the enforcement discretion, what's happening is Da Vinci, as the author of these implementation guides, is actually looking at making changes to CRD and DTR, the first 2 steps, so that there will be the ability to effectively issue a prior authorization number without going through the whole prior authorization X12 278 transaction to get one. The point being, really what's happening is a provider, if they get an okay, the answer is, you don't need a prior auth, just go ahead. There's a middle ground where you need approval, but we've got all the information we need, so we're giving you the authority to go ahead immediately without doing a full prior auth. The provider wants to get paid, so they want a number to be able to put on the claim saying you approved this. So there are going to be changes in those first 2 elements to allow that to happen. The enforcement discretion is allowing what was sort of a provisional number to effectively become a prior auth number. I'm probably not doing it full justice, but just trying to give you a flavor of some of the changes that are coming.
Terrific. And Rob, thanks for the CMS overview. And as all of you on the session today can tell, we have excellent expertise. Mark has been on several of the sessions. I participated in the small provider session on Monday, on the 8th. And there were some slides, and Michael shared in the slides, you'll get a link to it. But there were some slides that Bob Dieterle, I think, shared from a provider point of view. And if you think Mark has made this look a little overwhelming, you should see it from the provider point of view. For this session, and we're focused on the small payers, I'm thrilled to have a terrific panel. Rob, Michael, and others set up that panel, and it's terrific. But we have some rejoiners. We appreciate Karuna being on from Blue Cross Blue Shield Association, but we also have 4 small payer organizations that are going to participate. And why don't I have each of you introduce yourself? Let's, John and Dennis have been on earlier panels, so let's start with the 2 of you, and then Tim and your network health team, can you introduce yourselves, and Christina and your courts health team, and then we will also hear from Danny and from Brian with respect to their client base and what they're hearing and interacting with. And by the way, before you start, put your questions in chat. Rob and Michael, I'm going to ask you to help me track chat as I moderate. We don't want to miss the questions, but we do want to be sure we keep the flow of the session going. So let's go with the introductions. Start with you, Karuna.
All right. Hi, everyone. My name is Karuna. I'm with Blue Cross Blue Shield Association as a business interoperability lead. So at the association, we are the umbrella company that represents the entire Blue Cross system. Excited to be here today. Thanks.
Tim and team. We're not hearing you, Tim. Let's see. Maybe, Tim, while you're getting that, Bruce, do you want to step in?
Yeah, my name is Bruce Kissinger. I'm the Solution Architecture Director at Network Health, and I report directly to Tim Riley, who's our CIO.
Terrific. Are you back, Tim? No. Okay. Elizabeth and Sarah?
Sarah Danker, I'm the Vice President of Care Services here at Network Health. So under my purview include care management and utilization management. And I don't believe Elizabeth is able to join until after 1.
Terrific. And give us a heads up when she gets on. And we apologize in the promotions. We had Sarah as the VP of, was it pharmacy? I don't know if that's a pass, but it's care services now. So thanks for jumping on.
Thank you.
Christina and your team at Courts Benefits?
Hi, Christina Salm at Courts Benefits. I am the Vice President of Medical Management Operations. So I work with the care management, prior authorization, utilization management, and behavioral health teams. I have with me Julie, who is the Director of Utilization Management and Prior Authorization, and Joe, who is our Manager of Technical Services.
Terrific. And bringing that frontline experience as a small participant, small player in this area is great. John and I didn't see, is Brian on? Let's take it in that.
John Rascoviak, San Francisco Health Plan. We are probably the smallest payer you could probably ever have on a panel like this. And I'm responsible for all the EDI and interoperability for the plan.
Thank you, John. And Dennis, I'm sorry I said Brian, but I meant you, Dennis.
Hello, I'm Dennis Zuzak. I'm the Chief Technology Officer at Health Partners, and we are a payer headquartered in the Minneapolis area and a provider in this market. So we look at interoperability from both perspectives, and happy to be part of this.
Thank you. Tim, did you get back on?
I believe I'm on now. So.
Oh, you are good.
And I'm, again, Chief Information Officer here at Network Health in Wisconsin.
And so, Brian and Danny?
Yeah, Brian Poteet. I'm with EdFX. I'm a product manager here working on prior authorization and value-based care initiatives to some degree as well. So happy to be here and talk all about prior auth.
And hi, everybody. My name is Danny Kaywin. I work for MCG Health. We've several of the different small payers on this call are our clients. Nice to see some of you again. And we've done a lot of work around implementing some of these prior authorization APIs with several different health plans. And so looking forward to the conversation. Nice to see you all.
Did I miss anybody on the panel? I get everybody? I think I did. This is one of the best panels that I've had the opportunity to moderate. As I said, John and Dennis were on the second of the 7 sessions that WEDI has sponsored, which was peer-to-peer APIs, but it was more the national plans. And as we've gone along, we've realized and added the small provider and the small payer session for these types of discussions. So, let's jump into this. As Rob and Mark had introduced, CMS has laid out a framework for really a completely new approach to exchanging patient information and doing prior authorization. And it's kind of 2 components, and we will hopefully the way I ask the questions for the panel, we'll be able to address those 2 issues separately. But it's new standards. It's new workflows. As been said, there's an opportunity, but at the same time, there's some significant implementation challenges. And as we as healthcare stakeholders evolve from, oh, this is simple, to Mark's starting to tell us about the complexities, and we're probably sitting here today perplexed about everything that's going on. We've discussed all of the components over the last 6 sessions, and now this is our opportunity to jump in as small payers. So let's start with Christina and Dennis, and then John and your teams, Tim and your teams. So let's take it, Christina, Dennis, John, and Tim, and respond to the perspective from a small payer point of view with respect to the final rule. It's transformational. We know there will all be lots of requirements, but IT doesn't get all of the attention within your organization. So the question is, how have you and/or will you cultivate support from your organization's leadership for the time, the money, the resources necessary to implement this final rule? Christina and Courts Benefits, start us out. And for all the panelists, if you have comments anywhere along, raise your hand down in the function area. Rob pointed us to it, but it's under the more reactions. You can raise your hand, and between Rob and I, will try to have the panel flow in a discussion as you respond to the question. Christina?
So getting the leadership buy-in and support is key. It's crucial. And we do have I don't know if you want to call it luxury of this being a regulatory requirement. So it's a have to do and not a nice to do. And at Courts, we are taking a project management approach to this so that we have buy-in throughout the organization and can assign resources from the beginning. Right now we're putting together our own roadmap of what that looks like to get us throughout the key milestones. And it's discussed every week at the CEO direct report meeting, where we're at, what needs to be done, what are the barriers, and where we need to flush some more things out. So I think that we've started out on a good path. Of course, every project, right, has its challenges and some things that come up along the way that are unforeseen. But we've got a good basis here to have a collaborative relationship, because so much of this is technical, but it also has deep impacts on workflows throughout the organization, as well as the member and the provider experience. Everybody needs to buy into it.
Julie and Joe, would you add to that?
The only thing I had to add was that we were, you're looking at the time frame for implementation, and there wasn't one of us that looked at that like, oh, we've got all this time. It was like, oh my gosh, that's all the time we have. So we jumped on it right away. And we tried to approach it not only from this is regulatory, which I agree, Christina, feels a little bit like a luxury right now, but also approaching it from the positive aspects that this is going to bring to our membership, and bringing that to the table as well. And really, in the long haul, how all of that connects with our strategic plan as it is, and our strategic initiatives, long-range strategic initiatives. So we did come at it from that way as well. Joel?
Yeah, and I think looking at it from working and collaborating with our legal and compliance teams and understanding the rules, and also doing the reach outs to our vendors we partner with, or the systems that we use, kind of understanding what their plans are, and then really getting a breakdown of, okay, we have this goal. This is the time frame we're working under. What are the building blocks in order to set in stone and work toward in order to achieve that compliance state? So we've done that evaluation and kind of shared our thoughts and collaborated with our vendor that we have, and we are actually underway on a project to kind of leverage some of that initial building blocks from an auth perspective in order to be able to leverage that future development that they're bringing forth to kind of help appease and meet those overall requirements. But we're tackling it from a kind of a first, let's tackle this first step, get us where we need to be, and then once the year comes around, what are the next steps we have to take? So kind of taking an iterative, but also looking at the roadmap, the end goal, kind of as long as we're contributing to that. And I think that's what we're doing right now. We'll get there, but it's definitely a process. And there's a lot of work to do.
Terrific. Dennis, how's Health Partners?
So I think we're in a good spot in that our leaders understand the need for this, both as a regulatory requirement and the potential opportunity. The thing that we are also doing is starting to build out the business case for going beyond the compliance and looking at what the benefits are for the organization, as well as our members and our providers, and then with that we will be building out our roadmap. We know that the due dates will be here before we know it. We're not starting from scratch. We've got a good foundation in terms of our data, and we've got we've got a partner in place today. And then the other thing that I would say is that we are also tying together the work for this initiative with other interdependencies. So for instance, we are replacing now our utilization management software. And so making sure that we have a roadmap that integrates that to, into the actual data exchange piece of the interoperable So
Excellent point that this touches a lot of other systems.
yeah.
And so what you're saying is look at those other systems as well. Opportunity to take advantage of the ROIs that will be there, and we'll come to questions on that. John, you said you're probably the smallest pair. In the session that you were on before, you've made some headway already, but how have you gotten that support within your organization, and what advice would you give for the attendees today?
In our I basically have the mantle of having to be the evangelist for interoperability. Our compliance team, they just depend on me. And then the vehicle I use is I basically start RFPs early, and I get the requirements. I it's an easy to open a project internally with the PMO, and then that requires the business to have to participate, and that then educates them. So actually, I already have a draft RFP done. I was ready to go thinking that I didn't know the date was going to get bumped until it was published in January until 27. I was planning on the 26th, and I was already in my sessions. So I've already educated everybody. So, and then the RFP vehicle is basically foolproof because everybody has to buy in, and that's utilizing the process we have internally for any project, any evaluation. And also we're driven, it's not about are we going to do it or not. We're driven by our state Medi-Cal contract states we will be compliant on time. So, that becomes a non-issue. Because we signed the contract. If we want to keep doing our business, we got to do these things. Payer to payers in there, everything else is in there.
So you're a great orchestra conductor across the organization. And I suspect, Tim, at Network Health, you're in a similar situation. Describe the plan a little bit more, and then between you and your team, tell us your thinking on this question of resource allocation and like that.
Sure. Again, with Bruce and Sarah on the line and soon to be Elizabeth, those are my how and what's that we need to define. Likewise, like other panelists, we've been working primarily in the first quarter here with the compliance and our regulatory teams. As Mark pointed out, some of the regulation addresses even the training material. Well, then we have our corporate communications and those that we'll be bringing on board. Upcoming here, I think even this week, right, Sarah, we're meeting with our care management authorization vendor and getting their roadmap. And from there, that's where we'll be foundationally defining that. Along with the interoperability vendor, I mean, again, we're going back and reviewing our lessons learned from the prior years of becoming compliant with those regulations. I'm sure everybody on this call is aware of certain vendors that entered the market and then left after, and certain payers were stuck with replacing the original interoperability platform. So Bruce or Sarah, you want to add to our approach at where we're at right now?
You hit it on the head, Tim. I would just add, like others have indicated, we're formulating a project and doing a gap analysis, meeting with our current partners, our current vendor partners, understanding what the current capabilities are and what their roadmaps look like, so that we can do a full gap analysis as an organization to know where do we have to go, what are the holes that are going to need to be filled, and do so by the dates that we're required to. And as mentioned by others, it's not a nice to do, it's a must, it's a regulatory requirement. So we have the support of our senior leadership team and the CEO because we have to do it. But where do you allocate the resources and move off of other would have been nice to do projects to now shift to these new requirements?
Anything to add to that, Bruce?
Nope, nothing to add. That sums it up.
Great. And one observation, just as a participant here across the other sessions, I think it's terrific that Network Health, Quartz Benefits, you're pulling into the discussion while you're still pulling it together, the entire touch points, the team members, the executive team that is going to take to accomplish this. And that is terrific. Brian, EdFX is out in the marketplace. You're supporting a lot of people there. What do you see as the top challenges, especially small payers that they're facing and standing up a FHIR API and like that?
Sure. I mean, I think there's the obvious one, which is resources, right? The smaller an organization, the less people there are generally to implement and drive these sorts of things, which kind of increases the information load of those mental clearinghouses that have to understand all the moving pieces to get things implemented end to end, right? So I would say understanding those resources, and what I'm hearing is that you guys are trying to address that and bringing those people in. That's the perfect thing to do, because these processes are broadly cut across both the clinical and the financial kind of wing of the organization, right? You've got the clinical operations and you've got the revenue cycle, making sure that the authorizations still apply to the claim, they're still issued the same way, so you want to be sure that you've got that strong team together. And I think that can sometimes be a challenge for a small payer if you've got a lot of people wearing a lot of different hats. But then again, it could cut the other way and be a benefit. But then it makes it harder because you've got one person responsible for so many different things, right? So I think balancing that resource, commitment and really understanding what that looks like is probably the key thing. And, understanding, especially if you've got multiple vendors involved, make sure you've got primary contacts that are staying in communication with each other about these different pieces and parts. Because one thing, in working with Da Vinci and, organizations like Danny or Mark with Onyx, there's going to be a lot of interdependency between the vendors on how this stuff is going to be done. So understanding your vendor kind of footprint when it comes to this sort of thing, and all the different moving pieces, you could dive in. It's like what I call measuring coastline, right? There's many steps of this process where the further you zoom in, the larger the task looks, right? So be very diligent in your scoping as well, to say, okay, let's get one thing done and then let's iterate, rather than being caught up so much in all the details, and lean on your vendors for that. We have the expertise. We've been working with Fire for years now. It's something that we can help your organization kind of get that knowledge base and that thinking pattern of, hey, this is a new way to implement things. And there's a lot of benefits that come with it, but you have to kind of drive that expertise through your organization to make it truly successful.
So I don't think you said it this way, but maybe CMS needs to have a vendor-to-vendor API that they require. Before I come to you, Danny, Mark, I want to go back to you because you've been on a number of the sessions, and in some of those earlier sessions, you've commented about the complexities of the peer-to-peer APIs. And just in Monday's session on the small provider side, I kind of heard a theme that, well, what the providers have got to do is to really get the EHRs working. And after that, the payers are going to solve all the rest of the problems. So with your knowledge of the systems and the workflow and the technical processes and changes that have to be there, what do this audience, the small payers, need to make or to do to work effectively with the Fire apps and the Fire API, Fire apps and the peer APIs?
Good question, Tim. First, what I would say is, really, I think what you want to be looking at is finding the right partner to work with, because the complexity of everything that needs to be done, you need to be, as Brian said, you need to be talking with, working with folks that are really dealing with this day to day, in working out how you implement these Fire APIs. How do you plug in, for example, your pharmacy benefit manager, because they may provide you with Fire APIs for elements of your overall service. I think we are going to see things on the provider side. I don't think it's going to be the individual provider querying these APIs. It's going to be what I'm terming, as I'm writing the specifications, a provider representative, which may typically be the EMR. And so I think what you're seeing is ONC is driving the EMRs to continue upgrading and providing capability. So you may find that a lot of the big EMRs will provide the provider interface to do the prior auth, right, and connect to all of the payers. I think we're seeing TEFCA coming in, and how will that address, how do you get connected to everybody securely? We've got to work together as a community. I think that's the biggest thing I would say to any of you is don't try and solve this problem alone. Right? This is, as you look at how do we codify all of these medical guidelines, you're going to have to work with your UN vendors to get that codified. If you are doing that yourself, you want to get with a community that's doing the same thing so that you can share the load. I think that's the key thing is find the right partners to work with that really understand what's happening. What we've seen from dealing with, we've talked with a lot of payers, and some of you folks on the call are clients of ours, and you can go to the utilization management part of the organization and they have no clue whether there's a patient access API. And you're going to have to build on that to be able to comply with the other part of the rule of sharing data with providers and other payers, because otherwise you potentially become subject to information blocking complaints. So there's a lot of things going on here. You really need the right partners to work with.
Perfect. And John, you have your hand?
Yeah, it's just right on this topic. I went to HIMSS a couple of weeks ago, and I've been looking and talking to my providers, and I went and talked to some of their vendors like Epic and Cerner. And what I'm finding, just to this theme, everybody has their own version of Epic. Epic won't, at this point, create a standard interface. And they actually are saying, oh, it's up to each individual provider. So that means for us, it's like back to the EDI world. If you want to do a lot of directs or you use a clearinghouse, there is no clearinghouse. I have to then work with my potential vendor to go back to each of my providers that I need to connect with and say, hey, you need to give me access so my vendor can have access to your Epic, so then I can, establish this API to do this exchange. At the same time, of course, we've talked about it. I got a new care management system we're implementing. I've gone to them and they're like, oh, you have to go buy a module to connect. And so the company is like, wait a second, we have a whole bunch of money we had to put out, now to just do this one connection. So so this is a real problem, and that has to be solved. I mean, and the payers can actually drive it. It's like what Mark was saying, it has to be, it'd be great if somebody had a common interface, but we haven't. I don't know how tough that's going to be.
And before we go to you, Danny, Mark, and are you going to respond to the questions of
I was going to respond to John. John, great comments there. A couple of things that we're seeing, and I'll maybe pull in Daniel from MCG on this, because what we're seeing is some of those early testers like Cambia that have built some of this. They're now talking with organizations like eHealth Exchange to see whether the provider app that they built can be used by other providers, right? One thing I would say to you as payers is don't get fooled into thinking you've got to produce your own provider app, right? Because the last thing we want is for the provider to have 20 different apps sitting in their workflow in order to do a prior auth query, right? What we are likely to see is either it's going to be the EMR vendors will create the capability within the various workflows of the EMR, or organizations like the emerging QHINs may well bring an app so that when they're connected to that provider organization, the provider has one way to do a prior auth query, right? So I think it is going to get solved, but that's one area that I think you do not need to worry about as a payer. You want to focus on what you need to do in catching those queries coming into the APIs that you've got to expose.
Perfect.
I hope that helps, John.
And there was a question on the 278. Let me see if I can pull that up, or can you see it, Mark?
Yeah, I saw that. I think it was more about the 275, 277, where they're asking for additional information. And what we've got is within the burden reduction implementation guides, PAS actually points to the clinical data exchange IG, but CMS doesn't recommend that IG. But CDEX has been really designed in that scenario to be able to ask for the one-off questions. Can you send me this piece of data? Okay, so again, it's another capability that if your vendor or your interoperability vendor that's supplying your prior auth solution here provides that clinical data exchange capability, that can also short circuit more X12 transactions in that they'll be able to submit those one-off queries, whereas the bulk of the data collection will be sort of statically codified in documents, templates, and rules.
Terrific. And Danny, I know Mark has tossed a little bit your direction as well, but you know, from an MCG's perspective, as you're out assisting the payers already, how difficult will it be for smaller health plans to identify the FHIR and the other endpoints for the payer-to-payer and payer-to-provider and payer-to-patient access APIs?
Yeah, so we do a lot of work on the prior authorization API, actually, specifically. I'll touch on those others very briefly. I think some of those other APIs, when we start thinking through, I think Mark, I caught just the end of Mark's overall slides and sort of moving into, I think he said it well. From my perspective, some of these APIs for smaller health plans, they're going to start to help level the playing field between the smaller health plans and larger health plans, because you will have access to a lot of the data that some of those bigger health plans have access to. They've done a lot of work over the years. I come from a very large national payer before working at MCG, and we did work on integrated health records back in the day. A lot of that work is going to be available to many longitudinal health records, be available to the smaller payers through some of these pieces. I think when you think through the prior authorization API, I think there's an element of this where at a large scale, it may seem much easier for the big national payers to do some of this prior authorization API work. Everybody is making an investment in this, right? And everybody needs to get a return off of this as well from our perspective. And so when you think about that, the big national payers actually have a similar problem to some of this very small regional health plans, in that in any specific region, right, healthcare is not delivered nationally. Healthcare is delivered locally. The return for health plans on building something like the prior authorization API, provider access API, is actually providers using it. And so driving provider behavior is a key part of this from a health plan perspective. And so, you know, John and some of your team and a few others, Christina, Network Health, you all have certain covered lives in certain areas. And how close of a relationship do you have with some of those providers to try to help drive adoption to sending prior authorizations into you, like Mark was just talking about, and having people actually use these APIs? You might have closer relationships with a lot of the providers in your area than a Aetna or a Cigna might, right? So they can take their investment and spread it over a broader area, but you might have an easier way of getting people to actually go and use this. And so that's something to think through for specifically. I'm going to use Courts and Network because you all are in the same state. It's hard for, you know, to get some oxygen in a state like Wisconsin because Anthem is there. I guess Elevance, sorry for the Elevance folks on the phone, but Elevance is there, right? But together, you all have a decent number of covered lives. From the provider's perspective, the point of all of these rules was burden reduction for providers. And when we think through that, having the providers come to you and work with you if you all decide to use the same vendor for certain elements of this rule, like Mark was talking about, or you have the same entry point from the provider's perspective, it becomes a more powerful story for both of you to tell together as we go. So that's one of the things we've observed working with big health plans. We've worked with some regional health plans as well, Medicaid, MCOs. Provider adoption is a critical part of getting all of these APIs ready to go. And providers think about it in very much this will require a provider to change their workflow. And so who am I changing it for? Am I changing it for someone who I'm going to send 5 authorizations a month through the prior authorization API, or 1,000 authorizations a month through the prior authorization API? It's a big difference, right? And so when we think through that, finding opportunities for working with other payers in your region is a critical thing for smaller health plans from our perspective. And you all have smaller networks. You all probably have closer relationships with a lot of providers than the big national plans do. And so in some cases, from our perspective, you're actually better set up for implementing some of these requirements than some of those national payers because of that reason right there. Lot there, but think through the provider experience. I appreciate Mark kind of teeing that up to say the provider experience part of this is critical. And that might be, and Julie, I know we've probably talked a little bit about that in the past, but I'm sure you have thoughts there. I saw your hand get raised, but I'll turn it back to Ferris to, oh yeah.
So Dennis and I talked yesterday, and Dennis in his introduction said he was both a health plan and has relationships with the providers as well. And Danny, you've mentioned that. It isn't cheating to have a competitive advantage that you take advantage of as a small payer to compete with the large nationals. In my 6 years working with Optum and United, the relationship between payers and providers at the national level may be dramatically different than the relationship that we have as small payers working with a very small or close community. And I don't know, Dennis, before we go on to the other questions, any comments on what Danny's mentioned as a relationship? Is that an advantage?
Yeah, well, I think it definitely is. And, I too worked at United Health Group for many years, and the scale can, get in the way, and the complexity. But I think that relationship and working together, with a common end in sight really helps with, not just doing the mechanics of the interoperability, but thinking through what helps us better support our members, our providers, patients, and helps us, be, viable businesses so we can continue to deliver those services, and understanding better how how a provider is going to use the information, how it shows up in their workflow, and helping and understanding what the limits are of their system. And so in our market, one advantage, sometimes a disadvantage, and I'm sure courts and network have a similar experience. Almost all of our providers are on Epic. So, understanding where Epic's going and how they're going to support interoperability will be important. But, every provider will have decisions to make on how to consume, the payer information, and how to make it useful to the care team. And so I think that's where the relationships and working, in our case, with our network management team as they engage our providers is really key.
Perfect. And Julie, I missed your hand up, and John has a hand up. So before we go on, let's get your additional comment.
Sure, no worries. I think from the small payer perspective, the thing that we do leverage and will is that we've been working with our providers for the last 2 or 3 years on how to lessen the burden of prior authorization. So this is not a new topic for us. We've been talking about this for 2 to 3 years, and because we took a very intentional and proactive approach to that early on, even before this rule was put forth, we know what the providers, weak points are. We know what they want changed because they've been saying it all along. So when I look at this grocery list of requirements that we have to put forth, I'm checking off the list. Yep, they want a way to know internally from Epic, does it or doesn't require PA? That will be an enormous change, positive impact to our providers. And then to be able to request a prior authorization, basically at the same time. We have the benefit of knowing from these prior conversations and ongoing conversations, what are the pain points that they're going through? And we're using that information in our talks about interoperability to leverage how we move forward and encouraging them to get on the bandwagon, if you will, and work with us instead of, not work against us, but do nothing, right? So this is what we're using to leverage them in moving forward, is their own words.
Terrific. Thanks, Julia. John?
Yeah, unfortunately, this is kind of a downer type. California invented, or said all the providers, payers must be connected to the California Data Exchange by January. So 1/3 have done it. And what happened was a lot of them, particularly on the provider side, said, we're just not going to do it. We don't want to do the work. There's no enforcement. Then they tied it up in legal. So what we've seen, city and county legal won't sign off for the more public hospitals like Zuckerberg SF, San Francisco General Hospital. So they're not in. And so this has resulted in a real education. And I've been talking to the providers already because we do the EDI. So I'm already talking to the providers. I got directs. I'm talking to them about these APIs. They just don't have the stomach for it, nor do they want to. And then they're going to just not do it on the schedule because there's, even with the state and the feds, there's just not enough teeth. So this is going to result in gaps. I mean, they're not participating in the data exchange. They're not in HIEs. They're not, wanting to do it. So this is a real problem, much less than saying, hey, give me access to Epic so I can do this connectivity. So again, I want to make sure there's a right perspective. I've seen this across the whole state, the data exchange meetings, where even the state representatives are getting up and saying, yeah, we have a compliance issue.
Appreciate you saying that. And John, it is never a downer to live in San Francisco. I lived there for a few years and loved it. But you've raised another point, which is it isn't just the CMS final rule, but we all work in a state or multiple states, and we have other things going on at the state level that impact this. I'm watching our time, and I'll check in with Michael and Rob on when we actually should be ending. But I have a lot more questions here, so I'm gonna move ahead, and let's go back to each of you as health plans and kind of go in reverse order. Let's start with you and your team, Tim, and then Dennis and John and Christina and the network or the court's benefits team. But we've touched on this, but let's just be sure that we've clarified or shared all the perspectives on what are your organization's short-term versus midterm. The long-term goal is to get there, but are there any things that stand out as short-term or midterm goals in moving forward with your implementation efforts that we should share with the participants? Tim and Network Health?
Yeah, I think I just got Bruce on the phone right now and Elizabeth joining soon, and this would have been a good one with her. But during the second quarter here, we'll be lining up our vendor assessments, completing them as to what we want to do. This follows our annual preparation for projects for 2025 funding, as well as the creation of the budget that will be in full gear by August the annual budgeting process. And with the ownership change of Freighter and Ascension, and Freighter owning us 100%, we have some other planning procedures to do. So like a 3-year strategy with a 3-year financial plan. And so there's going to be some stress on that, or stressing of that on during the second quarter here. I hope that helps answer what you're asking. But
It certainly helps. Anything, Bruce, you would add to that?
No, but I think part of your question was goals. So, obviously some of those key goals for tracking metrics are some of those things that are relatively easy to put in place. We do some of those things now. So those will be some important first sort of steps for us. And then I think the other thing we're looking at also is, what do we need to do to modernize our patient access API? For example, when we started off, we talked about new requirements and new standards available for some of those things. So we're taking a close look at some of those things as well.
Okay, Dennis and John, and then Christina, your team.
So we're doing some of the same things, building out our roadmap, assessing what our existing vendors' capabilities are, and making some decisions on whether or not we move forward with, say, an RFP for parts of the end-to-end solution. I think one thing that I should have said explicitly as well is, our architects are looking at what is the end-to-end capability that we need for UM, and for the other pieces of the rules. What do we have all of the data in place to support that? We believe that we're in pretty good shape, but we need to double check that. And that work, understanding where we are in terms of our data posture, and where our vendors are in that supporting our need for the end-to-end solution, will help us understand how much work we have to do and the cadence of that. And so, we'll make sure that we have the data we need to do the reporting for 1/1/2026 first, and then we'll be building a proposal for building out or filling any of the gaps in the end-to-end solution that we need for interoperability and interoperable UM.
Terrific. And Mark, you have your hand up before we go to
just really
some questions in chat as well for you.
Yeah, just building on what John was saying about, we have a compliance challenge in California around some of the California regs. Let's be realistic about this regulation and the APIs. We're not on 1/1/27. I'm pretty certain we are not going to see 100% adoption of these APIs by every provider out there, right? We are probably going to, you probably have contact centers taking prior auth requests. You may have fax banks. You may have a provider portal. You may have other methods for people to be able to submit a prior authorization query and get a response. Those will still exist. So for those stick in the muds, let's call them, that haven't changed, they'll stay doing that. But one thing we haven't talked about is, the fact that when testing has been going on using these FHIR APIs, that providers have seen like a 230% improvement in efficiency by being able to use these APIs. So you are going to see a shift over time across to these APIs as more people adopt them, and it's basically also starts to cover more areas, right? So this is a transition. All of these CMS interoperability rules have really been about driving us on a journey.
Terrific. And and Marlene's offered some statistics that kind of support the evolution that's going to have to take place. Back to the short and medium-term goals. John, anything more you want to add before we hear from Christina and her team?
What my methodology internally here doing the RFP, well, it got enough attention. So then when the regulation, and that was pre-regulation. So when the regulation came out, we actually were in position with an educated business team. And then we pulled together an interim project very quickly, got all the components, the various teams together with the business to meet that reporting goal. And they've already started defining requirements. So then I said, like, next year we'll do the full RFP for the API. Otherwise, I'm in good shape because I already did payer to payer because of the state requirement. We've centered in my roadmap, I centered everything around Edifax. So there's my Edifax commercial. And then I've already reached out to them and they're going to give us a roadmap on their compliance in May. And we'll just build upon what we have because outside of the off, I don't have to go to RFP by our internal rules. I can say, okay, Edifax, what's your roadmap to get us there? How are you going to enhance the payer-to-payer? How are you going to enhance patient access? And then I'll just bring it back here and let our executives know. But that's the most cost-effective way. And so I don't have a problem there at all.
Perfect. Christina, back to the short-term, midterm. Has it been answered, or you seen some different things, you and Julie and your team?
Yeah, this is Joe. I'll speak for Christina here, and Court's behalf here. So we have looked at, like, we worked with our vendor and just try to address, like, what are these things we had, and as I mentioned previously about building blocks, what are those pieces we have to put in place in order to get us into a state where we can make that next step. So there's a couple pieces where we're looking at leveraging where we maybe not have leveraged our full capacity of our vendor to do certain things. They have released new features that will enable us to move forward with our limitations we had with the prior auth experience, but also help us meet some of that first building block for the reporting period information, or the 1/1/25 reporting period start time. We could put that, we're making steps to put that in place. One of those big features that'll not only meet that reporting period kind of like requirement, have all the data sets in a state that it's easier, or makes it easier to report on, but also improves workflows in the process. So it's kind of like we have to do this from a compliance standpoint, but this will also add some extra benefits to just from this first building block for 1/1/25, that'll add to our capabilities that will just make the experience better for our users, makes compliance reporting easier, and whatever. So it's really, I think our vendors really looked at this like, yes, we have to do this, but this is our opportunity to kind of like push and put us and give us more of those enhancements that'll make our experience better while also meeting the compliance deadlines from that perspective. So we've taken some strides, and I think once we kind of get through this back half of 2024, we'll definitely continue to push forward in getting the rest of the building blocks set in stone. But it's going to be kind of an iterative kind of approach, getting that project submission set forth, put it together, get it submitted by end of year, and then we can really push forward in getting those other pieces. And and also evaluating our vendors in the process. Is what we're doing today really the right approach? Is it the best approach we have for us going forward, or is it taking a step back and looking at it from a different angle? And so I think we'll be doing that, but I think this requires an iterative approach, putting those building blocks in place while keeping that distant eye focused on that end line and making sure you're taking the proper steps to meet that.
Great. Karuna, we haven't heard from you, and you've been on a number of these sessions. And so really share, especially with respect to small payers, what you anticipate Blue Cross Blue Shield Association, the other associations can really do to, what role can you play in assisting the industry in implementing the final rule?
Thanks, Veris. Yes, I think overall we're very excited. There's an appetite. We do see a range of plans from small to large. So what we're hearing has been articulated by many of the panelists already. So I've been appreciative of hearing that. And I think, we are in a stage of sort of innovation in our ecosystem today, and smaller plans are going to have to adapt. And I think one of the panelists mentioned that, you could see advantages both from a small payer and a large payer point of view. And while smaller players might not have the resources to be as explorative as some of the larger resources, we are saying that at the association, we can provide some value as a partner. So we're doing that in the form of, awareness. So we might tell a larger plan to participate in connectathons, et cetera. They have some more resources. With the smaller plans, it's really about informing them of what they need to be aware of and what they may not know. And to the rest of the panelists' points, where are some vendors that are really excelling in this, and what are some best practices from peers that they can leverage? Where do they not have to reinvent the wheel, and where can they get more bang for their buck? You might see at the larger plans several different divisions, some specifically for regulatory compliance, some specifically for provider applications, some for business ops. In a smaller organization, as we've heard today, you'll hear a lot more tag teaming and a lot more streamlining of strategies, and a lot quicker to get to the top to get that buy-in, which can be an advantage. So at the association, awareness not only to the plans, but also from the plans. So we're actively involved in HL7 and all the work groups, especially the Payer Provider Information Exchange work group. So we'll bring up concerns that we're hearing. I think there, it's been brought up that TEFCA is something that can help streamline some of the implementations that are going to be required between multiple payers and providers. This is predicated on something called a trust framework. Trust frameworks are pretty common in the provider landscape already, but they're pretty new to payers. So that's some awareness building that we can do at the association to build trust in the trust framework models. Some other concerns are things like provenance or primary source verification for quality reporting. So as the plans are getting more sophisticated with collecting their data, we offer a service called the Clinical Data Exchange Hub, where smaller plans can do a one-stop shop to source data from a national point of view. So they're not having to go do those multiple contracting negotiations across limited staff. So we do have, GPO efforts, et cetera, where we find the plans are definitely the smaller plans are especially benefiting from that. And as we're moving forward, we're looking into things like collective tool sets, standards repositories, code bases, Jira Confluence. Where are ways that we can create network effects, amplify the pain points and the needs, and really solve those for the industry? Because coming from our vantage point, we hear you, we hear all the sides of the issues, and where can we move the needle, knowing that it's not going to be solved overnight. And then the last thing I'll say is accountability we can provide. So there's accountability from a regulatory compliance point of view. I know Mark has a CMS compliance tracker tool that you'll actually see that some of the smaller plans at the Blues are in fact compliant compared to some of the larger plans. So I think that, as we are doing a better job of tracking and supporting our plans, we'll get more insights into, how we can move the needle and create alignment across the industry, starting with some of these smaller players that can leverage from the industry advancements.
Terrific. Brian, you have your hand up, and then Karuna, there's in chat a question about publishing and transparency. And I also want to acknowledge, I see Lorraine Liu was on. I missed all of the 90 or 100 attendees, but I'm thrilled that CMS was willing to get on and listen to the discussion. That's the WEDI secret sauce. So Brian, and then back to you, Karuna, if you have any response to, was it Kathy? Kathy's question. Brian?
Yeah, the only thing I was going to add in the prior discussion with, I think, John and Joseph, about kind of looking at your capabilities, don't just look at this in terms of the bounds of 9115 or 0057. Also look at some of the capabilities you might have already invested in for, say, things like patient cost transparency or No Surprises Act. There are similar capabilities, I think, with the advanced DOB requirements around knowing whether a service requires prior authorization or not. So there's a good chance that you've got a core capability that can be used and applied forward in these other contexts. So, that is something from a small payer perspective that can definitely help control the cost, as long as you've got your architecture done in a way that you can easily reuse those components, which is a key kind of fundamental tenet of how FHIR is built, is kind of building up those core resources and reusing them, extending them, et cetera. So that was just going to add on to that point as well. So.
Terrific. Karuna, on publishing, educating.
So I'm trying to understand, is this essentially publishing the rules that would essentially be built into the DTR? And I see Danny has his hand up, so I'm not sure if you have something to comment on this
Danny?
topic.
Sure, I can comment on that topic. Yeah, so Kathy, I think the rule, I think a lot of health plans have a lot of their prior authorization requirements published, right? I think what CMS is sort of calling out with this rule is published where. So I think that's the critical point, is you can put these all over, your public facing websites or provider.healthplan.com. And I think that's what's been done today. And I think what's happening is we have provider customers at MCG who work with over 50 different health plans. So are those providers expected to go see all of the published requirements out on 50 different health plans published websites, or should they be able to stay within their EHR and just say, hey, here's the payer, do I need an authorization for this particular customer? If so, okay, what are the requirements? I think that's what CMS is saying is the latter, is no, you shouldn't have to go out to where these are all published. Rather, you stay within your EHR, stay within your workflow, and have the payers come to you with their prior authorization requirements. So hopefully that helps. I did want to add on to what Brian said as well, expand that concept to say, as you're going through these, what other organizational transformations are you trying to do? There's a lot of health plans that MCG talks to that say, we're trying to build up relationships with our providers and help our providers more at the point of care, provider access API. We're trying to automate utilization management, prior authorization API. Make sure that some of the business elements that you're trying to do, a lot of these regulations touch those, and they touch those very closely. And so if you can actually take the goals that you have from some of these business investments that you're making in digital quality measure evaluation, I think Karuna talked about a little bit earlier too. So take some of the different investments you're making, as a small health plan or as a large health plan, help scale some of those investments by combining them with some of the organizational upswing around things like regulatory compliance. And don't just check the regulatory box. Set yourself up for a foundation for some of those business goals that you're trying to accomplish. So well said, Brian. I just wanted to add on to it that Brian is saying with past investments, I'm also saying yes, and with future investments. It's important to think about combining some of these different threads within your organization and using some of the groundswell around compliance, but also the goals around what are you trying to accomplish from a business perspective to bring these things forward together is the best way to do it from our perspective.
So I'm going to take that clue, Danny and Brian, and sort of pivot the discussion. We've heard in the last almost an hour a lot of the word compliance, but there's we do need to comply, but is there another face on this, which is the real opportunity to automate and remove burdensome data exchange processes? So I'd like us as a panel to share perspectives on, some of the opportunities that are associated with the regulation and how best to achieve those or take advantage of those, especially, again, for small payers. So let's go back to our health plans first. Christina, Dennis, John, and Tim, and your teams. Specifically, we talked about CRDs and DTRs and PSs and all of the terms, but is it doable? Can we really help the industry? Is there an opportunity to shorten the decision time on prior authorizations from 72 hours to or 7 days on critical ones? Give us your thoughts on the opportunity side of this, and then we'll go into some of our final questions.
I can go
This
first.
is a great opportunity. Oh, sorry, John.
Go,
It's,
please, feel free.
it's probably one of the biggest opportunities we've had in a long time. To enhance the payer-provider relationship, to enhance the patient experience, to make everything just a little bit easier. And I think that I've heard over and over again, right, is that we're using this foundation of we have to do it as a way and a starting point of, but we also want to do this and this and this and this and this. And it's an opening door for us to start the work that has been talked about for years. And I struggle a little bit with the provider adoption, but, you know, having my roots in I also appreciate it because we'll have done our part and the providers will need to step up and do their part, which will, in some cases, maybe force some people to come to the table that just weren't interested in doing it before. Julie and Joe have done a great job over the past several years in building relationships with their counterparts at our different organizations and providers. And I've done it at my level. So we're working both ways to the middle to make sure that we are getting all of the perspectives on how this can be done correctly. It is going to be very iterative. We are not going to get everything right the first time. We're not going to get everything we want right away. But as long as we keep that ultimate goal in mind and keep working towards that, it can only get better.
Terrific. John, you were next.
To me, you know, this is like one of the weakest points within a plan. I mean, I was at a Blue, and they actually undid all their workflow and automation and all. And then there was no drive. And I put together the analysis and the resourcing and said, why don't you automate this? Why don't you make it where you don't have people and you can be more efficient? I also look at, so this is going to drive it. And I have to drive it here at SFHP because the business will is right now is happy getting faxes, which is like ridiculous, you know, and, you know, it's just something we have to drive. And an EDI guy, I like to do that, and it should. And then also it's going to enhance the patient experience. I have a family member that's just gone through another year of trying to get auths for major, you know, services. Then the auths are wrong and they're declined and they have to go back and there's no reasoning. So this regulation, you know, really touches home where I have to help and make phone calls to say, why are you rejecting this off from the provider? And I'm helping the provider, you know, so because I have the knowledge. So this really is a major opportunity across the board for a plan, a payer, a provider, and then for the individual to have a better level and experience in the healthcare industry.
Thanks, John. Dennis?
Yeah, and I completely agree with John and Christina's perspectives. I think we saw a small win in this space years ago. Minnesota required electronic prior auth for pharmacy, and you know, again, in some ways, it's a simpler problem, but it was iterative, and what we saw is, you know, end to end, you know, we have the data exchange layer, and we have our solution, and we need to codify in a way that we weren't used to our prior auth decision making, and expose that all through standard transactions. And it took a while, and we were ready by the compliance date, but our ability to take advantage of that automation and that data flow took a while, and it was a joint initiative across the payers and the providers in our state. And you know, it still can get better, and I'm sure that we're going to go through a similar process here. I think one of the things that we're trying to move on right now that I forgot to mention earlier is starting to better understand how we need to codify our rules so that they can plug into this process and so we can do more automatically and turn decisions around faster.
So at the heart of this is trying to overcome all of these silos and separate worlds in healthcare into a more collaborative and interactive and really 21st century situation. Karuna, I want to come back to you with a question that at a broader global level you might have some insight on, and as was mentioned right up front, this doesn't apply to commercial health plans. How do you anticipate the parts of the payers and the parts of payer organizations that are not covered under the rule in reacting to the new prior authorization APIs?
I would agree with the rest of the panelists in terms of the business value sort of speaks for itself, and some of the data that we've seen with the ROI around prior auth implementations, et cetera, makes it very attractive from not just a required mandated point of view, but from a business opportunity as well. And so I think part of the struggle will be meeting the providers halfway, but plans, I know at the Blues, we have an interoperability North Star to go beyond the federal requirement and focus on clinical data for access by all members. So I think, we're grateful that the policy is, geared in a consumer-oriented way and is intended to improve the experience. And, we're supportive of expanding that to the rest of our commercial lines as well.
That's the hope. And that's part of that opportunity question that we've asked. Compliance is this part of healthcare. Is there an opportunity to make it all of the part of healthcare rather than just separating out the pieces? And I think that's really important. Brian, how do you see small payers calculating or dealing with the ROI, the value that will come from the technology that they're investing in?
Yeah, I mean, ultimately what I'm seeing is, especially I think getting into Danny's point about choosing those initiatives where you have alignment and kind of opportunity, what you find really is it's kind of good news, bad news. The good news is the choices become obvious. The bad news is you have to make the choices. And I think ultimately to realize the ROI, you're going to have to make a choice to say, am I investing in my OCR tech to keep scanning my faxes, or am I investing in maybe my newer pathways and a business initiative to drive volume out of fax, make the newer pathway more attractive than fax, right? And because if you try to chase both, you'll eat your ROI up all day long, right? You're going to have to make a choice. That's kind of, and each choice is valid. You could say, you know what, my market, there's not a lot of adoption of EHRs because maybe I've got a rural base or something like that. I'm going to be dealing with faxes for the next 15 years, no matter what I do. Maybe it makes sense to enhance that and, get that capability to where I have less interaction dealing with sorting all these faxes and stuff like that. That's a completely valid choice and may make sense for you, but you're going to have to choose, right? Because I don't think you can really address adding a whole other channel that have to support for some of your lines of business and keep enhancing all of these channels capabilities. At some point you're going to have to choose and say, okay, where am I steering this ship eventually? And I think that will really help you ultimately recognize the ROI. The more modern you can get, the higher the opportunity is for that ROI.
Terrific. And I want to acknowledge Chris's comment in the chat, and I see a number of thumbs up on it. His point is that the full end-to-end prior authorization, the goal is really to get to point of service, that a patient's with the physician and it's done. 72 hours, 7 days is a lofty goal, but really isn't the goal I use many times, the rest of the world has moved from taxis to Uber. And with an Uber app, when I'm coming out of one meeting and going across town to another, I put in where I'm going, and I have a full set of information. I have the answer to my questions, what it's going to cost. We're not there as healthcare. So 72 hours, 7 days, that may just be the point. Mark, you have your hand up, but I also want you to sort of share as you respond to how you see small payers effectively managing their multiple trading partners, because you got payer to payer, you got payer to provider, you got payer to patient. We've discussed it. There's a lot of people to work with. How do you see small payers dealing with that? But take your first hands up first.
The hands up, I was going to build on what Brian was saying, that if you think about it, if providers do adopt this, for those of you that are payers that have actual commercial as well as regulated lines of business, how long do you think it's going to be before those providers say, you mean I still have to send a fax to the commercial line of business, but I can get an answer in 5 seconds for Medicare Advantage, right? It's going to drive this from being a compliance objective to being a business transformation opportunity. And also remember, the data that's been coming out of testing so far is saying, as a payer, you are likely to see the number of prior auths drop, because now a provider is not going to be submitting a prior auth just in case. And if they submit one, you've still got to respond to it to say, hey, you didn't need to send this in. So there are benefits to both provider and payer that's going to drive adoption. It's not going to be immediate, but it is going to happen. You are going to invest more in these APIs. Now, as to provider access API, payer-to-payer API, these are things that there are going to be benefits to you in terms of payer-to-payer, for example. You can try and get more data to be able to manage your patients. Imagine enrolling a new member and they agreeing to share their health history, and now you can look at what programs do you need to get them on, what prior auths do you need to put in place to see that they have a smooth experience and they don't become a high-cost member, right? The same with provider access API. Providers are wanting more data as well as payers in many cases. And so you will be managing the attribution lists. And there's a whole set of things that we've been defining in the PA Data Exchange IG about that you'll define an attribution list. There'll also be ways to actually, you can choose to trigger impending treatment relationships. So somebody turning up to a new provider, you could potentially release data to that provider around the data that you've got. And remember, for the plans, you typically may have broader data than an individual provider. I know that may not be true for people like Quartz, where it's largely a payvider situation, and you may have a lot of the information, but the plan has the advantage of pulling data from the pharmacies that they went to, the other specialists that they saw that may have been out of network, and all of that will add value to this whole process.
Terrific. Benny, how challenging is it to digitize a health plan, especially with respect to prior authorization?
Yeah. Ask that question again. Sorry, Ferris. I think you cut off.
So we're talking about APIs and all of this electronic. As you work with your vendors, how challenging will it be to digitize health plans' prior authorization policies to support CRDs and DTRs and everything else for the small player?
Yeah, I mean, I'll take them a bit separately to say the coverage requirements discovery piece. If you think about is an authorization required? Small payers might actually be better off to answer that question. It might be easier for you all to answer that question if you don't have 3 or 4 lines of business, 7 or 8, massive employers who carve out their own rules for all of this stuff. That's where, thinking through that question becomes extremely complicated when you think about some of the big payers. For a lot of what we've seen is a lot of small payers, that question is actually easier. There's fewer benefit plans. The provider network is more is closer to home and a little bit more open. And so on coverage requirements discovery, I think that could actually be easier, but smaller plans might actually be an advantage there. When we think about documentation, templates, and rules, I think Mark and Brian both said, think about where your vendors can help you. Think about your current utilization management vendor. Almost every health plan has one. MCG is one of those for a lot of your health plans. Doing some of this digitization of medical policies work, turning them into FHIR questionnaires, building some of the CQL elements around those. That's a tremendous amount of work. See where your vendors can help you. We've done it. I'm sure your current vendor has explored it, and they can give you a demo of it. Certainly MCG can do so. So think through that process and what that looks like. See how your vendors can help you on prior authorization support, that last one, and CDEX to a certain degree. Think through the interactions part of that. So when we think through as a health plan, maybe some of you all have used Evacor for certain types of reviews, or AIM or whoever as a delegated vendor, and you already have somebody who pushes cases into your system. That's great. And you're probably going to need some back and forth capabilities built on top of that to support something like prior authorization support, like these APIs. So there's human users on the other end of this, no matter what, no matter how successful or not we are as an industry at implementing these specifications, these implementation guides. No matter what, there will still be humans on the other end of this. So there will be some back and forth, making sure your system is gentle enough in the implementation of these to allow for some of that back and forth, that it's not once it's here, and I can't change it. And if I need to change it, I need to create it again. Those are some of the pitfalls we've seen as we've gone through and implemented this in a few different health plans. So maybe a longer answer than you were looking for, Ferris, but I think if you take each piece of this as a separate entity and say, what are my gaps as an organization? How am I going to fill those gaps? And then at the end, making sure it all sort of strings together. That's a zoom in on that problem, as Brian said earlier, and make sure that you're seeing it in its entirety.
Terrific, Danny. Mark, you have a comment, and then I'm going to give the panel sort of a final two-part question so we can wrap up here in 10 or 15 minutes.
So what I was going to build on what Daniel was saying, if you think about these APIs, the prior authorization APIs, they're not really actually changing the actual process of medical guideline review, right? Somebody will still look at that and make a decision. What they're really doing is saying, what data do I need to make that decision, and make sure you collect that up front and pass it through. And ideally, do that in an automated manner so that the provider is just filling in the gaps, right? So in that way, when you take the medical guideline, you're not trying to codify the whole thing. You're really looking for, what is the data I need to make the decision? And so what happens today, I guess in many cases, is someone submits a prior auth request, and a request goes back, send me this data. They send that in, and then another request for the next bit of data goes out. And so it bounces backwards and forwards a number of times before getting to a decision. And if anything, this rule will help gather all of the data that you want for the most popular decisions you need to make, and make sure that's all available up front, so it can either be decided automatically, or it's all there in one shot to go through to make that decision.
Perfect. My final question, and actually apologize, John had to drop. John had referenced an RFP process that he has been going through. The question really is, especially for the small payer audience that we're talking with today, what level of customization? Are you expecting an off-the-shelf solution? Christina, Dennis, Tim, or is there customization that you're you feel you're going to have to need. And then the other part of that question, if each of you can deal with it, is that have you chosen a provider that will collaborate with you in the testing process? You just don't want to implement and then roll it out to everybody. So customization, advice to our audience, and then where are you at in choosing a testing environment for what you're developing? Christina, let's start with you.
All right.
And your team.
I would say yes. There is absolutely going to be some customization. Having a certain level of out of the box is great to get things started, but as you, especially working as a smaller health plan with a smaller region, there are certain things that are unique that we just aren't going to encounter in San Francisco or at United or what have you. So I absolutely expect there will be some level of that. You know, we are in Wisconsin, we're in Madison, Wisconsin, and Epic is our neighbor. So they've been a great partner to work with as we have been looking at vendors and solutions and the things like that, offering us some guidance and looking at the fact that our providers and our sponsors are all on Epic. It seems like it would be pretty natural to move along with that system. And we feel pretty comfortable with that piece of it. My thought as I am listening to all of the excitement and all of the challenges that folks are voicing is it's starting out with specific lines of business, specific, you know, CMS and Medicare, Medicaid, all that good stuff. I want to do it for every line of business. If we're going to take on this level of a lift and the resources that it will take to get it going and maintain it, we might as well pull the Band-Aid off and just do it for all lines of business so that not only do we see the efficiencies on the payer side, but our providers see the efficiencies, and more importantly, the members see the efficiencies so that the care is impacted in a positive way, and we just keep moving forward. If we do it in stages, I think that will just cause some noodling and back and forth that we wouldn't necessarily have if we move forward saying, look, we're doing it all at once.
And I'm seeing lots of thumbs up for your comment. Do it for everyone. So Dennis and then Tim, what are your thoughts on customization and also testing partners?
Yeah, I'm hopeful that we don't have to do a lot of, you know, customization. I'm sure there will be a lot of configuration. I think that a lot of the work that we've seen with interoperability, you know, you'd say the consumer facing interoperability a lot of it has been data and making sure that our data conforms to the standard, and then understanding and evolving as the standards change. So I think that will continue to be a unit of work that we do. I hope that especially for we will get to a place where we can use it across all of our lines of business. We support all the multiple lines. But I would say that the commercial is where a lot of our complexity lies, both in terms of our network configuration, benefit coverage, prior auth requests, or prior auth requirements, medical policy variation. So we may end up having to stage some of that. And so those are the kinds of things that we'll have to factor in as we do our roadmap. And to your question about vendors, we have a vendor and we're looking at what they can do and whether or not we need to go to market to supplement what they can do or replace what they can do today.
Terrific. Tim?
Yep. I mean, I'm in the same pattern Dennis is. So ditto, I can say on what he's working on right now during the second quarter here, as I mentioned earlier. I do believe there is customization. I'm going to have Bruce comment on where his perspectives on that is, and testing. You know, when you look at the comment Marlene Larkin put in the chat, where CMS is predicting that in the first year only 27% of the providers. I don't know what I'm looking forward to seeing the provider presentation, how they may be reacting. She also noted that the CMS mentioned 50% in 10 years. So that is going to be what helps me with that is, okay, now I really have to find the right testing partner, the one out there that would be a part of the 27%. So I'll end with that. And Bruce, do you want to comment?
I'm sorry. Go ahead, Bruce.
So when it comes to customization, I think one of the things to ponder is that, you know, the implementation guides and these requirements are at various levels of maturity. And I think that's the one big elephant in the room, speaking as a person who's had to implement this stuff before, that many of them are not yet fully baked. Many of them are still at a trial for standard use sort of level of maturity. So I believe that until those standards get more finalized, either through a standards making process or just through, you know, sort of de facto, this is how everybody does it, so this is how you need to implement it, there will be a lot of customization. I'm frankly not that optimistic about being able to buy something from a vendor off the shelf and have it plug and play and work. And I suspect, again, you know, for folks who are lucky enough to have all of their providers use Epic, that might be one thing. But even there, I still think we're going to see a lot of differences in terms of the data and how it's sent and things like that. So I'm not anticipating actually that this is going to go smoothly.
Thank you, Bruce. And I have to thank all of the panelists. This has been an excellent discussion, and it's we haven't solved all the problems. This is not going to be easy. This is hard, but it's going to be good. And there's great opportunities, but limitations. I also want to thank the participants, because this isn't the final word. I've got a whole list of other questions that we could talk about. So I'm going to pass this back to you, Rob, to wrap us up and tell us how we can continue this conversation and check in with each other.
Yeah, no, a phenomenal discussion. And I think the one thing that excites me the most is I'm hearing optimism. I'm not hearing, oh, whoa, this is another compliance exercise. So I think that bodes well. And I think if there's one thing that I would recommend is reach out to your providers, get them discussing this, get them excited about it, because this is only going to work if we all move at the same time. And I think that's going to be the challenge. And, you know, we're going to be discussing this and other issues at our spring conference. I would encourage you, it's a virtual event, to attend and keep these issues coming and keep the momentum moving. And I just wanted to thank a few folks before we close. Mark, as always, you know, a phenomenal resource. Really appreciate you sharing your expertise with our audience. Ferris, phenomenal job as moderator. You know, the old adage of herding cats does not quite apply here, but the panelists did a phenomenal job. You know, we've heard from some small payers that they didn't want to participate because they weren't already started, and we told them, no, we're all in this boat together. So I think hearing from your panelists what their journey is going to look like was extremely helpful. As well, I want to thank our sponsors, EdFX and MCG, obviously wonderful resources, and I know they're going to be willing and able to work with all of you to help you reach your goals. Thanks to CMS, they've been involved from the beginning. I know Lorraine dropped, but she's been a great supporter of WEDI and our education throughout this series. Big thanks to Michael McNutt behind the scenes. He makes it all happen seamlessly. and he's able to get really wonderful speakers for our series. And finally, I want to thank all the attendees. Great comments in the chat, but this is only the beginning. So we encourage you to get involved, whether it's through WEDI or other organizations. We have to work together to make this happen. So with that, we will close and look forward to seeing you at future WEDI events. Thanks so much.
Thanks, everyone.